As has become well documented, the situation in Europe due to COVID-19 is dire. But what is particularly horrifying is how many of the nation's elderlies are being neglected during this time. BioEdge reports that not all of the human drama in COVID-19 pandemic is cheeriness under pressure, heroic doctors and nurses, and the generosity of neighbours. Some very bad stuff can and probably will happen. Nothing illustrates this more vividly than what happened in Spain. Recently, military units seconded to help in the crisis entered various residential centres for seniors in Madrid. What they found was appalling. Some of the residents were dead in their beds. Others were wandering around in, quote, a state of complete abandonment with poor hygiene. It sounds like a canto in Dante's Inferno. And worst of all, the care workers were nowhere to be seen. They appear to have fled, terrified of contracting the coronavirus themselves. For these residents, it must have been the worst death imaginable. Alone, helpless, choking, without any accompaniment in their last moments. Even more shocking, according to the English translation of the Spanish newspaper El Pas, many seniors have fallen ill in care homes without ambulances taking them to hospitals. Some family members have said that their parents or grandparents are being left to die because they are considered lost causes, as they have prior medical conditions or are of an advanced age. If there is any positive to come out of this unmitigated disaster, maybe it's that people will reassess their view of euthanasia. For as we are seeing, it is the elderly who are most vulnerable in relation to COVID-19. As the experience in Spain tragically shows, there needs to be legal protections for people in tragic situations such as these. What follows are 10 reasons why we should all be opposed to doctor-assisted suicide. First is the obvious potential for elder abuse. The European Court of Human Rights has stated, quote, that the risk of abuse inherent in a system which facilitated assisted suicide should not be underestimated. Following on from this, Dr. Pritchard of the University of Tasmania writes, in the coming decades, we face a rapidly ageing population, a shrinking tax base, and increases in health problems like dementia. Euthanasia could very well form a part of government planning for service provision for people nearing end of life. If that sounds far-fetched, consider 2 cases from Oregon in the United States, where patients' applications for medical treatment were rejected, but followed by departmental notifications informing the patients that they were eligible for assisted dying. Second are the bioethical reasons. You see, at the heart of this issue is the role of the medical professional. In particular, are they a healer, a helper, or a killer? Significantly, a national survey in the United Kingdom has shown that the majority of doctors do not support the practice of euthanasia. What's more, the Australian Medical Association has been highly critical of the practice as well. Dr. Christopher Middleton, a former president of the AMA, has said, I think it would completely change the mindset and the ethos of medicine in Australia because in their practice, in training, doctors tend to see themselves as agents of hope and healing and comfort, and certainly not as agents of death. Third, is the psychological pressure to end one's life. Note the following table based on statistics, once again from Oregon, which shows that since euthanasia has been made legal, there has been a significant and steady increase in people choosing euthanasia so as not to be a burden on their family and friends. Note that in 1998, 12% of people said that this was the reason for taking their own lives. But by 2007, that figure had risen to 44%. And then by 2012, it involved over 57% of people. Clearly, the figure is rising as more and more people feel the psychological pressure to not be a burden to their family and friends. Fourth is the negative societal perception of those who have a disability, with their deaths being treated as an act of compassion. Researchers have found that the implication that some people are better off dead and that some lives are not worth living, phrases such as these have been used internationally in euthanasia debates. But they are both offensive and stigmatising to those who live with the same or similar symptoms and conditions. Fifth is that of bracket creep. What has been observed in countries that have legalised euthanasia is that the wishes of family members have pressured the person to choose to be euthanized. What's more, there is widespread underreporting of the practice, and there has also been a significant increase in the use of terminal sedation, resulting in the patient's death. For instance, Dr. Philip Nitschke, one of the leading proponents for legalising euthanasia in Australia, has been quoted as saying, "In the intervening 16 years since the Northern Territory Rights of the Terminally Ill Act came and went, the debate on voluntary euthanasia has been extended beyond those who are terminally ill to include those that are well, for whom rational suicide is one of the many end-of-life options." 6. The safeguards of psychiatric referral and assessment are gradually ignored. For example, in Oregon, the percentage of people being referred for psychiatric evaluation has dramatically decreased, as can be seen in the following table. Note that while 31% of people were given a psychological assessment in 1998, when euthanasia was first legalised, in 2007 and 2009, no one had been referred. Another report has found that in the Flanders region of Belgium, approximately half of euthanasia cases are not formally monitored, as doctors do not report them to authorities. What's more, the rate of underreporting in the Netherlands appears to be between 20 to 23%. Seventh is the eventual practice and cultural acceptance of non-voluntary euthanasia. Once again, in Belgium, where euthanasia has been legal since 2002, it has been observed that people were put to death without their consent. What's more, nurses have taken upon themselves, without the presence of a doctor, the responsibility of administering euthanasia drugs. Eighth, numerous countries have examined and rejected the practice of euthanasia. It's worth remembering that out of the 195 countries that there are currently in the world, only 10 have approved euthanasia. And out of these 10, there are a significant number of states within those countries, such as within Australia, where it still remains illegal. As such, no country should feel that they are on the wrong side of history in rejecting this practice, when the majority of countries around the world have decided against its legalisation. Ninth, is the associated guilt that occurs when the medical professional is involved in ending another person's life. For instance, Dr. Kenneth Stevens, after researching this particular aspect, makes the following finding. He says, the physician is centrally involved in euthanasia, and the emotional and psychological effects on the participating physician can be substantial. The shift away from the fundamental values of medicine to heal and promote human wholeness can have significant effects on many participating physicians. Doctors describe being profoundly adversely affected, being shocked by the suddenness of the death, being caught up in the patient's drive for assisted suicide, having a sense of powerlessness, and themselves feeling isolated. There is evidence of pressure on and intimidation of doctors by some patients to assist in suicide. The effect of counter-transference in the doctor-patient relationship may influence physician involvement in euthanasia. 10th, there are gendered risks, especially for women. Alarmingly, there is a growing body of academic literature which highlights the disproportionate victimisation of women, especially in relation to euthanasia. As Pritchard and Graham once again explained, it is vitally necessary to carefully consider the potential for gendered violence and familial control to be directly or subtly influential, if not implicated, in matters of the voluntary assisted death of women. Where there has been coercion, control, and gendered violence in a woman's domestic life, the nature of which may often be kept hidden and secret from others, including in professional and personal relationships in her life. It is important to ask whether this might also be a factor in a woman's death. In wordspeak that would have made even George Orwell gasp in disbelief, the term euthanasia has been given a plethora of innocuous sounding alternatives. Voluntary assisted dying, dying with dignity, therapeutic homicide, therapeutic killing, mercy killing, and physician assisted suicide. However, there is never such a thing as a good death, as the proponents of euthanasia would have us believe. And the recent events that have occurred in Spain are a prescient warning as to some of the dangers that lie ahead in adopting it. Of course, it's not what people envisage dying with dignity will be like, but it's a horrific example as to what many people rightly fear will ultimately take place if legal safeguards and protections are removed.